Very good. That's fine. Right. So if you have read and understood considering this surgical and optimization, kindly tell me how, yes, if you're looking at the picture A and B, can you please tell me, can you please identify the bones? These bones are of which part of the body? I can hardly hear you. Can you bring mic closer to you, please? Can you tell me how a foot joint is formed with which? Yes. I can hardly hear you. Can anyone else hear me?
Foot joint or ankle joint.
Yes.
His network is poor.
Can you hear now?
It's very weak
Yeah,
voice.
can
We
you
can
hear
hardly hear
now?
you. Can you tell me which are the bones which form the foot of a human being? Or how many bones are involved in the formation of a foot? Can you tell me what
Ankle
are
joint
the...
is made from
Yes.
3 bones.
Yes.
Distal part of feet.
Yes. Okay, can you, I'm sorry I got disconnected. Can you please tell me what are
No
the
problem.
parts of the foot?
What are, ma'am?
The arches, what are the arches of the foot? How would you classify the arches of the foot?
Yeah, there is medial longitudinal arch, lateral longitudinal arch, and transverse arch.
Okay, can you please tell me with the help of which bones and structures these arches are formed?
Okay, so medial longitudinal arch is made of the calcaneus, talus, cuneiform, and medial 3 metatarsal, and lateral longitudinal arch calcaneus, lateral 2
There are
arch is
certain
made up of
certain
the
yes,
cuboid, cuneiform, and base of the metatarsals.
there are certain ligaments and muscles also involved in the formation of the arches. Can you mention those as well, please? Can you mention the ligaments and the muscles?
Would be tibialis anterior and tibialis posterior, and shard muscles of the big toe and flexor hallucis longus. And then for the lateral longitudinal or ligaments would be introitious ligament, plantar aponeurosis, and there would be shard plantar ligament. So these would be the ligaments, and then muscles would be peroneal muscles and short muscles of little toe for the lateral longitudinal arch, and for the transverse arch The ligament would be interosseous ligament, and muscles would be peroneus longus and transverse head of adductor hallucis.
Can you tell me what you understand by the term mid-tarsal joint of your part?
Yeah, ma'am. So mid-tarsal joint is actually also called the transverse tarsal joint, which is formed by calcaneocuboid articulation and also by the talocalcaneonavicular articulation. So this is as a whole, this is called as mid-tarsal joint, joint of Chopard.
What are the movements which occur at subtalar joint?
Subtalar joints, there is inversion and eversion.
Okay, what are the muscles which perform inversion and eversion?
Inversion is performed by tibialis anterior and tibialis posterior, and eversion by the peroneus longus and peroneus brevis.
Okay, what type of joint is an ankle joint?
Ankle joint is a synovial hinge joint, talocrural, also called talocrural joint.
Can you please tell me what are the movements which are possible at ankle joint?
So at the ankle joint is plantar flexion and dorsiflexion of the foot mainly.
Right. Can you please tell me why ankle joint is more stable in dorsiflexion position?
Right, ma'am. So in the dorsiflexion, there is a wider interior trochlear anger that fits with the tibia. So that's while in the posterior side or posterior side of the trochlea is more narrower. So that's why in trochlea, due to the trochlea's more wider interior side, its stability is more in the dorsiflexion, which helps
Okay.
in the movement.
What type of joint is inferior talofibular joint?
This is syndesmostic joint.
Okay. Right. What are the type of associated injuries with regard to syndesmotic fractures?
Yeah, so ma'am, there could be a lateral malleolus injury and there could be injury to distal T metaphysis.
If you have to take the pulse of tibial artery, where would you palpate?
For the tibial artery, posterior tibial artery, I will palpate actually halfway between the halfway between posterior to the medial malleolus and Achilles tendon.
Can you tell me the structures which pass behind the medial malleolus?
Okay, ma'am. So structure which pass behind the medial malleolus are flexor hallucis longus, flexor digitorum longus, and tibialis posterior, and then there would be posterior tibial vessels like posterior tibial artery and posterior tibial vein and posterior tibial nerve.
What are the muscles? What are the arteries of the foot, and how median and lateral plantar arches are formed? Median lateral plantar.
All right,
arteries
so
are
ma'am.
formed.
Right, ma'am. So artery of foot are dorsal pedis artery from the anterior tibial artery and the medial and lateral artery from the posterior tibial artery. So arch of the foot is mainly formed by the lateral plantar artery and dorsal pedis union. So that's how arch is formed.
Right. Can you please tell me what are the muscles which forms the Achilles tendon?
Achilles tendon is formed by gastrocnemius soleus and plantaris.
Right. We'll move on to the next. Yes. If you can quickly, bell has gone. But
Ma'am,
since
do
we're
you
going-
want me to identify bones of the foot in the picture?
Can you identify these circled ones, please? What these structures are? Picture C, D,
Okay,
and E.
ma'am.
Quickly, please. Yes.
Okay, so in the
Six.
picture C is from the medial view and showing the deltoid ligament And 26 is tibronavicular bone, and 18 is spring ligament or calcaneo
Right.
navicular ligament.
And what is
And
one?
picture D from the lateral side, this is anterior talofibular ligament, and 3 is calcaneofibular ligament.
Good. And
And
this 22 is pointing at what?
the tarsal sinus between
Good.
calcaneum and
In picture E, what is 3, please?
this is from the posterior side and show the calcaneofibular ligament.
19.
And 19 is showing the posterior talofibular ligament.
Right. Good. Thank you. And right. If you can tell me, what are you looking at?
Yeah, ma'am, this picture is showing the tendons and dorsalis pedis artery. So
It's
first of all,
basically
on the number 7,
dorsum of the which side of the foot? You have to identify that.
dorsum of the foot.
Right foot. Yes.
Yeah,
Can you
dorsum of
identify
the right.
7, please?
Extensor hallucis longus
Very good.
tendon.
Okay. 6, please. Over here.
Extensor hallucis brevis tendon.
Right. Okay. And then what is 1?
One in between. Sorry.
Arcuate artery. Okay. Number 2.
Arcuate.
Can you locate number 2?
Number 2. Where is number 2? Can you please point?
Yes. I thought you would.
Yeah.
2.
These are mid-tarsal arteries.
Digital arteries. See, these are with the
Digital
digit. All right. 18,
Okay.
please.
18 is tendon of peroneus tertius.
Tuberosity of the base of the fifth metatarsal.
Okay.
Okay, 12, please. Last.
Tendon of peroneus tertius.
Yes. Right. Good. Any other you want to comment yourself? Okay, what is 3?
3
It is tortuous and it is
dorsalis pedis.
very good. Excellent. Good. Thank you. Here is your question. Right. So if you have read and understood, considering the clinical examination session, kindly begin.
Okay. At first, I will enter into the room.
Yes.
Then I will wash my hand and I
Yes.
will greet the patient. Like,
Yes.
hello, I am Dr. Rifat, on exam candidate. May I confirm your name and age, please?
Yes.
Today
I'm
I've been
Lisa, 55 years old. Yes, continue.
Lisa. Today I've been asked to examine your hand. That includes look, feel, and move, and tapping over in your hand, and some special tests. Are you okay with that?
Yes.
Okay. For the examination purpose, I'd like to expose you. So, would you please roll up your sleeve for me?
Yes.
Okay. Do you have
Above
any?
elbow.
Yes, up to elbow.
Yes.
So, do you have any pain anywhere, Miss Lisa?
No, just numbness and tingling.
Okay. Then I would ask the patient to. I will ask to have a pillow, and I would ask the patient to keep their hand over a pillow. Then on the
Okay.
dorsal, I will inspect the patient dorsal of the hand. Like I will see skin color change, swelling, deformities, any nail changes, or any muscle wasting. Then I will ask the patient to roll around her hand for me. Then I will check same things again, and especially I will check in the palm of the hand, like any dupotor contracture, any thinner and hypothinner muscles, whether it is wasted or not. Then would you please bend the elbow for me? Then I will check the rheumatoid nodule and any psoriatic plaques. Then I will go for the feeling, and I will again ensure whether there is any pain or not. Then I will check the temperature, and I will check the radial and ulnar pulsation, and whether any tenderness. To check the tenderness, I'll do 2 tests. One is squeeze test in metacarpophalangeal joint, and another one is bimanual examination over all the joints of the hands, like metacarpal, interphalangeal, distal interphalangeal joint. Even I will palpate over the anatomical snub works to whether there is any tenderness or not, which indicates scaphoid fracture. Then I will ask the patient to bend again to show me the elbow for me. Then I will again palpate to whether there is any rheumatoid nodule on the ulnar aspect of the elbow. Then I will go to the third step for the movement. So would you please make a fist for me?
Yes.
Spare for me. Put the palm of the both hand together and face upward, and to see the extension of the wrist joint. And would you please put the back of the hand together and face downward to see the flexion of the wrist joint. Then I do the same thing, passively, flexion and extension. Then for the flexor diaphragm profundus and flexor diaphragm superficialis, I will check these two tendons function. For the flexor diaphragm profundus, I will establish the proximal interphalangeal joints and ask the patient to flex distal interphalangeal joints. And for the flexor diaphragm superficialis, I will keep the straight all the fingers except which would be examined. So I will ask the patient to flex the proximal interphalangeal joints. Then I will ask the patient to follow me for the thumb movements. So for thumb movements, I will do flexion, extension, adduction, abduction, and opposition movement of the thumb. Then I will go for the hand function. Would you please grip my finger? Then for the power grip, and would you please pinch over my finger with the thumb and index finger? Then I would ask the patient to unbutton the shirts, upper two button, or I will keep a coin and ask the patient to pick up the small coin for me. Then I will go for the last step, which is neurological examinations. Neurological examination comprises 2 steps. One is sensory. So I ask the patient whether he is feeling the cotton wool, which will be touched in the forehead of the patient. Then I'll ask the patient to close his eyes. Then we'll touch the cotton wool in the little finger for the ulnar nerve, over the index finger for the medial nerve, and over the anatomical nerve box or OAV space, dorsal OAV space for the radial nerve. Then I will see the motor function. For the motor function, median nerve, I will ask the patient to face the thumb upward to the ceiling, and please don't let me push it down to see the power of the abductor pollicis brevis. And for the radial nerve, I will ask the patient straight your fingers and wrist against resistance, and I want the patient to adapt.
Okay. Can you summarize your examination now, please?
Okay, ma'am. To complete my examination,
Yes.
would like to perform elbow examination and neurovascular examination of both upper limb. Today I have I have been examined 45 years female Lisa, who came with a tingling sensation, pain over the right hand. On inspection, there is a wasting in the right thinner muscle, and on no other any abnormalities. In the power, there is a sensory loss of the median over the medial nerve distribution.
So what are your
and
provisional diagnosis for this patient?
The clinical findings, my provisional diagnosis is carpal tunnel syndrome.
What are the other differential diagnoses you will consider?
Cervical disc prolapse or diabetic neuropathy.
Yes. What investigations would you ask for in order to confirm your diagnosis?
Investigation, I would like to check the positive, underlying disease. To identify the confirmation of the diagnosis, I will do electrophysical studies that includes electromyography test and nerve conduction studies. And I also do for MRI scan underlying cause to carpal tunnel syndrome. And I can also do diabetes, blood sugar, hemoglobin A1C, and thyroid function tests also.
Okay. What are the treatment options you can offer to this
And,
patient?
it depends on the underlying disease.
Yes.
And conservative treatment. If I can treat the underlying disease and ensure the conservative treatment, most of the patient are cured. So for the conservative treatment, when CTS shows mild to moderate disease, then splinting in the wrist at the night for minimum 3 weeks, and I can do steroid injection for the carpal tunnel and not in a non-NSAID. And I can also use diuretics. And then if the CTS shows severe disease, then I can go for surgical treatment, and that includes carpal tunnel release.
Yes. Good. Thank you.
Thank you, ma'am.
And here is your question. Right. So if you have read and understood, considering the clinical examination station, kindly begin.
I'll enter the room. I will wash my hands. Good evening, good day, sir. My name is Dr. Nwachukwu Chukwunonso Daniel. I'm one of the candidates for this exam. I want to examine you, and I will be as gentle as possible. Can I confirm your name and age, please?
Yes, I'm Tom, 56 years old.
Okay, I will call you, can I address you as Tom?
Yes.
I want to examine you, and I'll be as gentle as possible. Can I go ahead, please, sir?
Yes.
Okay, it will involve my exposing my patient from the nipple line to the mid-thigh while preserving his dignity by ensuring that he has his briefs on. Then I would it would involve also taking a general inspection. I will inspect the abdomen from the foot of the bed, and I also examine from the side of the bed, stooping at the side to the eye level of the abdomen. Mr. Tom, is there any part of your abdomen that is paining you?
Yes.
Okay. Do you mind if I give you an analgesic for the pain?
That's all right. Go
Okay,
ahead.
so I'll be as gentle as possible. So then I'll start with my superficial palpation. As soon as I do my superficial palpation and the patient winces in pain,
Yes.
from the part I start, I will then know that this patient is having shortness of breath and with abdominal pain, severe abdominal pain. So I would then start assessing this patient using the CRISP protocol, which would involve the airway. Since the patient is talking already, I will assume that this airway is patent. I will then go to the breathing aspect. Mr. Tom, please, can you open your mouth, please?
Yes.
I'll open his mouth, check for central cyanosis. I also look at his chest wall for movement, whether they are equal on both sides. Then I'll palpate I'll palpate the chest. I'll palpate for chest wall expansion. Then I will percuss only the anterior chest wall and the lateral chest wall. I wouldn't percuss the posterior chest wall. Then I will auscultate both the anterior and lateral chest wall. Then I would assess for its circulation. Mr. Tom, please, can you bring out your tongue?
Yes.
I will check for whether it's dry, whether it has dry tongue. Then I also check for sunken eyes. Then I also look for, can you turn your face to the other side? I will assess for the neck veins. Then I also auscultate the heart. For disability, my patient is conscious. For my exposure, I would like to, I will tell my examiners I want to expose the laparotomy wound. Then when I, when I expose, then I will then go for, go look at my patient's calves. Then I will rule out a deep venous thrombosis and pulmonary embolism. I also look at the charts and then also look at the pulse, the respiratory rate. Then if there are any other lab investigations by the side and possible ECG, which I will have. Thank you so much. Thank you so much, Mr. Tom. I've finished my examination. I will get back to my consultant. Then I would report to my consultant what I found out, discuss with my consultant what I saw in you. Thank you, sir. Then I will offer to dress my patients. I'll offer to dress my patients and wash my hands. Right.
You still have 2 minutes left. Anyway, when you were doing breathing examination, then you should go out and check if the trachea is central or not. That's the only thing you have missed. Right. Neck veins, you've already, I think, checked, and the heart auscultation you've missed. Eye for pallor, you've already seen, I think. All right. Can you present your examination now, please?
I examine this 56-year-old male I examined this 56-year-old male who is a 6 post-operative day left collar cystectomy with generalized abdominal pain, which radiates to the left shoulder tip. However, the patient has a patent airway. It breathes well, and the circulation is intact. The patient is alert, and when I squeezed the calves for tenderness, there were no tenderness around the calf. My differential diagnosis is possibly generalized peritonitis secondary to anastomotic leak from left hemicolectomy.
How would you confirm your diagnosis?
To confirm my diagnosis, I want to do an ultrasound.
Okay.
Then I also want to do an abdominal pelvic. I'll do an ultrasound. Then I also do a plain abdominal X-ray, both erect and supine. Then I also do a CT with a gastrographin enema to enable to identify the leaking anastomosis.
Good. Yes.
Then I also do a chest X-ray.
Yes.
To rule out respiratory problem. I also want to do arterial blood gases.
Yes.
And then I also do a serum electrolyte urea and creatinine to assess the renal function.
Very good. And what are the management alternatives you can offer to the patient?
The management I'll offer to my patients is I'll start my patient first on neoperoral. I'll pass a urinary catheter to monitor the urine output. I'll pass an NG tube to suction and then for bowel rest. And then if the patient's condition is deteriorating, I will discuss with my consultant to transfer to the highly dependent unit to insert a central line and monitor. I will start my fluid station with crystalloids, give my patient IV antibiotics. Then I will discuss with my consultant that the patient might require an urgent laparotomy.
Very good. Okay. Yes. Yeah, that covers the management. Good. Thank you. Right. Started your timer and here is your question.
Shall I start?
Just a few seconds. You'll be able to hear the bell. 14 seconds left. Right. So if you have read and understood, considering its communication skills, patient, kindly begin.
Okay. Hello, good morning. I'm Dr. Krayasi, one of the senior house officer working for Mr. Mann, and I'm talking from Royal Hospital. May I know whom I'm speaking with?
Yeah, I'm Mr. Mann. You summarize the case, please.
Okay, I wanted to talk to the vascular consultant, Dr. John, to ask him about the patient's condition. Can I speak to him?
Yes, I'm Mr. John.
Okay, nice to meet you, Mr. John. How are you doing today?
I'm okay, thank you. Can you summarize your case,
Shall I?
please?
Okay. So there's this patient, Samantha, who's 52 years old and admitted to us for diverticulitis, and her symptoms were improving with the IV fluid and antibiotics. But suddenly she complains of having a right lower limb pain, which was sudden in nature. And we did some investigations on her. So her ECG really revealed atrial fibrillation with preventricular complexes, whereas her ABG shows metabolic acidosis and hypokalemia. So we were hoping to transfer the patient to your care. So that's why I was calling you.
Is it urgent, doctor? Can you send it tomorrow instead?
Unfortunately, the patient and the limb, she has this pain, and it's really urgent from as far as I know, because she might lose her limb, and so early intervention is necessary in this case.
Okay. So do you need a cardiologist for the preventricular complex before you transfer the patient?
Well, I think that the limb is much more serious than consulting the cardiologist right now, because yeah, we do need a cardiologist for reviewing her later. But as she's having this electrolyte imbalance, hypokalemia, and metabolic acidosis, I guess the preventricular contraction is due to that. So yeah, we need a cardiologist, but it could be done later.
Okay. And so what do you think of her presumed diagnosis of diverticulitis? Could be something else as the patient is having now arrhythmic or atrial fibrillation?
So as far as we know that she has this sudden pain, limb ischemia, and atrial fibrillation was also seen. So I would consider mesenteric ischemia as well. And so other differentials could also be appendicitis or ectopic pregnancy or pancreatitis, IBS or inflammatory bowel disease. She could also have that.
Okay. So do you want to scan the abdomen first before you transfer the patient?
Sorry?
Do you want to scan the
Do you want to
first?
scan her?
Oh yeah, I guess we have to scan the abdomen also, but it could be done later. First, we have to make sure the patient is being transferred.
Okay, so why do you think the patient is having mesenteric ischemia? You said.
The patient could be having mesenteric ischemia because of the atrial fibrillation and the limb pain she's having now.
Okay. And what are you going to do for that?
We are performing physical examinations, abdominal examination, and if we need some further examination, we will also intervene with the CT abdomen. But before doing the CT abdomen with CT scan with contrast, we need to do her renal function tests, and if it's normal, then we'll go for the CT with contrast. But if if it's not
Yeah.
normal, then I will progress with MRA or CTA or duplex.
And how you are going to manage this patient?
So as this patient is having hypokalemia, I will correct the hypokalemia by giving normal saline or dextrose water with KCl. And also I will correct the atrial fibrillation by doing the anticoagulants and the cardioversion. And also I will correct the metabolic acidosis. And so and for the limb ischemia, we will do thrombolysis or embolectomy if the limb can be saved. But if the limb is not viable, then I will go for amputation.
Okay. And how you are going to manage her atrial fibrillation? Is there anything you can do?
So for atrial fibrillation, we can give amiodarone, and also we will do cardioversion. Yeah.
Okay, doctor. And what type of ambulance you will need to transfer this patient?
Well, the best ambulance is the air ambulance, and we will make sure that the ambulance has the CPR equipment and the cardioversion equipment, monitoring
Okay.
of the patient for the monitoring.
Are you going to use any anticoagulant? And which type on the dose?
Yes, we can use unfractionated and fractionated heparin, but in this case, I guess unfractionated would be much better. I will start with the 5,000 international units as a bolus, and then continue with 150 international per kg per hour. And I will make sure that her APTT is in between 40 to 60 seconds.
Okay. What you are going to tell her family?
I will counsel the family that the patient has been developed this reduced blood supply in her distal limb, and that's why we need an urgent intervention, and that's why we are transferring the patient under the care of the care of vascular consultant.
Okay, doctor. You can send the patient over.
You still have
Okay, thank you so
1.5 minutes. So what is the new diagnosis that you have come across that you think could be?
The new diagnosis?
Yes? After
It
all
could
this
be a
discussion,
mesenteric ischemia.
embolus, mesenteric embolus, because of atrial fibrillation.
Atrial fibrillation. Okay.
Yeah. Right. So you said send for transfer. Okay. Right. Was there anything else you could ask? What is like explanation in yes?
Should we do the summary? Or we end it?
Yeah.
Or
Because after she has done, then whatever she has discussed with you. Yes, Dr. Daniel, you have raised hand.
Okay, okay, thank you, ma'am. I feel that was a fantastic presentation.
Yes.
But my question is, do we need to summarize at the end because we are discussing with our seniors in the call to a vascular consultant?
All right.
We don't.
Yes.
We don't.
Do we need to summarize? I just want to ask.
No,
Here
Do we
you
need
have
to
already summarized in the beginning. You have summarized the case, but at the end, when you have to when the consultant asks or gives all the orders, then you say okay, because here you have to ask for the permission if you can send the patient. So yes, at the end you don't have to summarize.
Okay,
but you
thank
have
you,
to
ma'am.
wait for the order. But in the beginning, yes, when she had to explain, then she had to explain in SBAR manner format. All right, good. Can anyone give her the feedback?
I think she did good. But for the management, I think one has to mention the CRISP protocol, like to manage this
Yes.
patient specifically.
And
Patient
what
with
about the
atrial
ambulance
fibrillation,
discussion on ambulance? She said a ambulance. What is
air
a
ambulance, air ambulance. Yeah, that's right.
Yeah. Okay, good. Right. Little advice from me because right, once a consultant asked you if you need to, if the patient needs a visit to cardiologist. So your first answer was straight no. No, we'll have that later. But then you thought and then you said yes, patient needs cardiologist, but we'll take care of that later. So always think, listen carefully and always come up with one answer. So instead of your first answer was wrong, it was right, but it shouldn't have been like that. Once consultant asks you if you need to, if your patient needs to have a cardiologist visit, then you'll say yes, of course, we understand patient needs a cardiologist visit, but this can wait. It's not an emergency. We'll transfer the patient first. So it's like you have to
Yes, ma'am.
rephrase, understand
You're
and
right.
rephrase your answer. Another point, when consultant asks you if you need any anticoagulants, instead of mentioning all the anticoagulants available in the market, you have to tell only one, which you told later on. First you said they are both fractionated and unfractionated. This will give a bad impression. Just say, okay, yes, I understand patient needs anticoagulant. Since patient has hyperkalemia, renal function is not good, so we'll give unfractionated heparin. And how much you'll give, you'll tell the dose later. So if you'll
Yes, ma'am.
yes, if you'll tell like this, and you'll just have to reread the management because you have to consider all the points in a better way, like Dr. Mohammed told you, CRISP protocol management and all that, and then tell. So it will give a better impression. Otherwise, it was okay, it was good. Right, thank you.
Thank-
Started your timer, and here is your question. Right. So if you have read and understood, considering its surgical pathology station, kindly tell me what advice would you give to the patient now?
For this case, the patient will need to stop smoking first,
Yes.
and then do lifestyle modification and then get the treatment with the hospital.
Yes. So it says carcinoid tumor invading pleura and lymph nodes. So what would you suggest to the patient? What advice would you give? What would be your next step of management, in other words?
Invading the pleura and lymph node that is aggressive, so the patient will need radiotherapy and chemotherapy.
Okay, you'll discuss with them deeply, and then you'll take the
Yeah.
next step. Okay, can you tell me what is the most commonly occurring cancer in UK?
Is non-small cell carcinoma, adenocarcinoma.
This carcinoma is found most likely where in the lung?
Sorry?
Where exactly is it found? How would you differentiate it from other types of lung carcinomas?
Adenocarcinoma is common in non-smoking non-smokers, and they are located peripherally. For small cell carcinoma, they are located centrally.
Okay, can you please tell me what is one simple non-invasive test which can be done along the bedside for the diagnosis?
Sputum culture analysis.
Okay, any other test?
Bronchial lavage.
Yes, okay, good. Can you tell me how would you differentiate between bronchogenic carcinoma and mesothelioma?
Bronchogenic carcinoma, they are really localized in the lung. For mesothelioma, they are widespread, diffuse malignancy. The separation between healthy tissue and cancer tissue is very not very significant.
And
yes. This is why it is difficult to get surgical incision for the mesothelioma compared to the bronchogenic carcinoma.
All right, okay. Right, can you please tell me what are the different types of lung carcinoma that you know?
Different types. They are small cell carcinoma, non-small cell carcinoma, and among the non-small cell, there are adenocarcinoma, small cell carcinoma, and large cell carcinoma.
Okay. What are the genes which are involved in for the diagnosis of lung carcinoma?
The genes, the BAP1 gene.
Okay, yes. What are the risk factors for the development of lung carcinoma?
Smoking, asbestos exposure, and then combined asbestos and smoking, zero mineral radiation.
Yes. Right. Right. Okay. You told me about the incidents and management. Okay. If you fail to manage a patient with lung carcinoma, what are the complications that can result?
And so there can be paraneoplastic syndromes features.
Okay. Can you please tell me what would be the significance of pleural plaques?
Pleural plaques, they are wide circumscribed plaques of dense collagen fibers, which later undergo calcification.
Yes.
And they are they have very high chance of changing into mesothelioma and adenocarcinoma.
If you will take the sample of pleura, how would that appear? What are the features that you'll see?
Can I come back to this question later?
Okay. Can you please tell me, if a patient presents with metastasis, mets, and they are very poorly differentiated, how would you tell if the origin is epithelial?
By immunohistochemistry strain or FISH.
Good, okay. Sometimes this tumor of lung cancer, it could be EGFR positive. How would you know? Then what would be the chemo drugs that are used?
I don't know how to detect that, but for the treatment, we can give a tyrosine kinase inhibitor.
Yes.
Imatinib.
Yes. Okay. Right. What more I can ask you on this? Is it like okay, a patient who has, if you want to determine lung cancer, how many biopsies would you take in order to confirm your diagnosis?
We can do imaging guided biopsy
Okay.
at least twice.
Yes. What is the treatment of lung carcinoma? Does it depend on the type, or is it the same management for all types of lung carcinoma?
It depends on the type. For small cell, they are chemosensitive,
Yes.
and they are more they can respond more to chemotherapy. However, they have poor prognosis.
Okay.
For other types, we can do remove surgery.
Yes.
Surgeries.
Which carcinoma spreads most fast?
Small cell carcinoma.
Yes, does not even wait. Okay. Which one is not associated with smoking? Which lung carcinoma is not
Non-small cell carcinoma, adenocarcinoma.
Okay. Why is it called adenocarcinoma?
Because they arise from the mucus producing glands.
Glandular epithelium, yes. And?
Yeah. And they produce mucin.
Yes.
And they are mucin stain positive.
Yes. And these adenocarcinomas, they are positive to which stain?
TFT1. TTF1.
Yes. Okay, good. Right. What more I can ask you? Right. If a patient has a carcinoma because of, okay, what are the dyes which are responsible for lung carcinoma? Can you tell? Which dyes or what?
H&E stain.
Yes.
Sorry, I don't know
People working
exactly.
in, yes, certain dyes and working in shipyards and yeah.
Yes, of course.
Good, thank you.